So thanks sir for introduction. My name is Dr. Ali Farehe and I am fellow in intervention cardiology in AFIC, and the topic for today's discussion is valve for life, a challenging TAVI case. I have no financial disclosures. Brief introduction of the patient. My patient was a 76-year-old male with low BMI and he was moderately frail. He had class 3 angina and dyspnea. He also had history of moderately obstructive airway disease. Examination showed ejection systolic murmur in the aortic area. At presentation, his creatinine was elevated. A EKG showed atrial fibrillation with LVH. His echocardiogram was done, which showed upper borderline LV with moderate systolic dysfunction and EF of 35%. He had trileaflet stenotic aortic valve with very severe AS and moderate AR. He also had mild to moderate MR due to mitral annular calcification. His angiogram was done, which showed moderate disease in mid-LAD. His MPI scan showed EF of 28% and it also showed mild infrabasal ischemia. This is the clip of his echocardiogram. As you can see, there is moderate global dysfunction and EF is around 30 to 35%. And there is also moderate LVH. Echocardiogram was done and you can see the LMS is normal. Circumflex is dominant. There is moderate disease in mid-LAD. There is also mild ostial stenosis in diagonal. And as you can see, the RCA is non-dominant and it has mild irregularities. And you can also appreciate that there is quite a bit of calcium in the aortic valve. Because he had class 1 indication for AVR, we calculated the surgical risk scores. He had STS score of 6.34 and Euro score above 8. So he was intermediate to high risk for surgery. So after discussion with patient, attendant and cardiac surgery department, we proceeded with cardiac gated CT angio with femoral vessel runoff to evaluate the possibility of TAVI. His mean diameter of annulus was 26. That was at the upper borderline of a 29 balloon self-expandable valve and at the lower border of 34 size valve. However, as you can see, the left and non-coronary sinuses were quite good sized. However, right coronary sinus was small. So that made him quite ineligible for 34 size valve, and that was at the borderline of the 29 valve. However, the right coronary ostium was quite high. It was above 15. So that gave us good safety about the procedure. Left coronary was also above 10 millimeter. It was about 15 millimeter. LVOT and STJ were both above 2 centimeter. Ascending aorta was non-dilated. Annular angulation was conducive for TAVI. His iliofemoral axis was quite non-tortuous with minimum calcium. So we decided for a 29 valve size for this patient. Patient had class 1 indication for transfemoral TAVI due to intermediate to high surgical risk and anatomy and valvular and vascular anatomy conducive to TAVI. So this gave him a class 1 indication for TAVI. His older age, trileaflet valve, absence of aortic dilation or complex CAD, moderate obstructive airway disease, frailty, all these points gave him a favorable risk profile for proceeding with TAVI. So this is a summary of the case, and after heart team meeting, it was decided to proceed with TAVI. So we took the main access from the right side. As you can see on this angiogram that the puncture site is quite between the inferior epigastric artery and the bifurcation. We took secondary access from the left femoral artery and we placed a V18 wire into the right femoral artery as safety wire. So then from the secondary access we put a pigtail into the right coronary sinus and we confirmed the coplanar view. Then we put the pigtail into the right non-coronary sinus and confirmed the cusp overlap view. Next, with the help of AL1 catheter, we placed a straight tip emplast wire into the LV, and after few wire exchanges we were able to place a pigtail catheter into the LV. At this time we loaded the 29 size evolute valve onto the delivery system, and the proper loading was confirmed on the cinefluoroscopy. Because of high and eccentric calcium, we had already decided to proceed with the predilation. Predilation was done with the minimal annular diameter. It was done with the 22 wax balloon, and as you can see, the balloon burst during the inflation. We took the evolute device, and in the cusp overlap view, we started deploying the device. You can see around 20% 10 to 15% of the device is deployed, and you can see we targeted the high implantation in this patient. So this was the picture just before the point of no return. As you can see, we have a very high placement. So we went for the complete deployment after the confirmation of the position of the device, and eventually we removed the nose cone as well. As you can see that the device is quite under deployed, so we proceeded next with post dilation. The post dilation balloon was selected as per the mean annular diameter, so this was a 26 size wax balloon. And after post dilation, you can see that we have good expansion of the TAVI valve. So this is the final picture, and we have a good deployment and low deployment. So actually the story starts from here. Patient collapsed at this point. We were actually transmitting this case live into a cardiology conference, and just before after going offline, the patient crashed. So his pressure dropped, he had an episode of VFib, CPR was started. So what could have happened at that time? So there were 3 to 5 possibilities. There could be an annular rupture leading to tamponade, there could be a coronary obstruction leading to acute MI, or there could be a torrential AR. Less likely possibilities could be an iliac perforation leading to RPH, and just to make up the numbers, I put in the complete heart block as well. So clues to etiology. Initial T showed some fluid around the heart, but later it was confirmed to be a pleural effusion. His transthoracic echo showed an EF of only 15% with hypokinesia of the anterolateral wall, and ECG, which on the monitor showed ST elevation in the AVR. This is an echocardiogram. As you can see, the anterolateral wall is quite akinetic. So here with a suspicion of LMS obstruction. So during CPR, we took the guide from the left side, and with the help of JL guide, we actually were able to take a picture. As you can see, the LMS ostium is totally occluded. So here the patient was totally collapsed. So we took a balloon, and with the help of the balloon, we peridilated the LMS, first with the 2.5 balloon and then with the 3.0 balloon. We tried to cross the stent into the LMS, however, stent would not go. So next we took a guide liner, and with the help of the balloon anchoring, we placed the guide liner along the tip of the ostium of the LMS. As you can see here, basically patient is having cardiac standstill. And just during CPR, we were able to actually push the stent into the circ, and the stent was deployed while keeping the proximal end of the stent into the THV valve. So this is the stent deployment, and you can see immediately after the stent deployment, the flow has returned to the both arteries. Post-dilation was done, and this is the actual final picture, where you can see in this caudal view that the flow is restored into the circumflex as well as into the LAD. So patient remained on inotropes for 12 hours. Immediate post-op echo was 20%. However, next day jump up to 40 to 45%. He was weaned off from inotropes in 24 hours and discharged on 4th admission day. So this is his pre-discharge echo. You can see the LV has come back alive. There is LVH, there is some MR, but there is basically a mild AR, and the LV is quite jumped up to 55 to 60%. So why this happened? Basically, there was a chunk of calcium in the left aortic leaflet, and that jumped into the LMS. So basically, this is animation at what happened. So we have the device, we have the aortic valve, we placed the device, the evolute valve, that was somewhat underexpanded. So what we did, we took a balloon for post-dilation, and this balloon basically did that. It pushed up the left leaflet into the aortic sinuses. As you can see, the left leaflet is pulled up into the sinus, and it has led to the ostial pinch of LMS. So next we took a guiding catheter, We were able to wire the circumflex, and this was a 0.04 soft wire. We pedalate the LMS, stent could not cross. So next we took a guide liner with the help of balloon anchoring, and then we were able to place a stent across the device into the LMS toward the circ. The device was inflated. After post-dilation, we had good final picture with patent LMS. So basically, I would just like to share this last clip. On the left, you can see the echocardiogram of the patient just before the device deployment. And you can see the EF was 35%. He had severe AS, which had been lingering because surgical turned down for last 2 to 3 years. And on the left, we have a very good left ventricle after the TAVI procedure. So a bit controversial statement, but just to emphasize the importance of structural heart disease in Pakistan, we don't know whether the stents work in stable ischemic heart disease. We had trials like Courage, Ischemia, and Orbita, which says that the stent don't work in stable ischemic heart disease. These devices, TAVI devices, we have bulk of data which show that they work not only in high risk and prohibitive risk patient, but they also work in the low risk patient. So this basically requires a massive emphasis and infrastructural development for the development of the structural heart disease in our country. Thank you.